Hi, everyone. Welcome again to Chats with Dr. Gege. So, I thought to just give some insight on what a pediatric pulmonologist is. I've realized that quite a few people don't really understand what it is I do or why we even need pediatric pulmonologists. So, to backtrack a little bit, a pediatric pulmonologist is first of all a doctor, okay? And then, based on our passion for the little people, we decided to study further, and we are pediatricians. So, to become a pediatrician in South Africa is a further 4 years of training outside of your general medicine training. So, I did do that. I trained through Wits University. All right. So I was a pediatrician for some time. I did and still work in a government hospital. And then I made the decision that I wanted to specialize further. And so I decided to study the lungs of children. So essentially, a pediatric pulmonologist is a children's doctor that focuses on the lungs. There are doctors who focus on the heart or the brain, and they are called other things. But a pediatric pulmonologist focuses on the entire respiratory system. So everything that has to do with breathing is what I would focus on. So that training is on top of the pediatric training that I did would be, depending on how you do it, either a further 2 years of studying, or if you're doing it part-time, up to 3. And because I did it whilst working my regular job of being a pediatrician, then it did take 3 years. And then you write an exam with the College of Medicine, and you do a portfolio of work, and there's also a clinical component to your exam. So that's that. So you may be wondering then why do we need a pediatric pulmonologist? I mean, aren't regular pediatricians able to manage coughs and colds and pneumonias? So the answer is yes. A regular pediatrician can manage a regular respiratory problem. Where we come in is when things get complicated. So, for example, if a child is admitted with, let's say, pneumonia, let's say it's a bacterial pneumonia, whatever bacteria that it is, normally a pediatrician would admit that child if they do need to be admitted, and they would give the treatment, whatever antibiotic, and that little one would possibly be on oxygen. And after a few days, they would get better and they would be discharged. But there are times where things can get complicated. So sometimes the baby can develop an abscess or cavities, holes in the lungs, or they could actually pop a lung, which is called a pneumothorax, or the actual disease progression itself might become so severe that it is now falling outside of the realm of what is the usual. So any respiratory condition that becomes more complex or is behaving outside of the norm, or is taking longer than what is normal for what it needs to be. And in all those scenarios, we anticipate that there are going to be long-term consequences. And so we come in to, first of all, help to manage that child. So we're going to come in and be like, why is this pneumonia so complicated? Why is this one not acting like the typical oxygen requiring, antibiotic requiring 5-day situation? You know, once these things are going on for 2 weeks, or the x-ray looks very abnormal, or it looks like this little one is maybe going to lose a lung or something, we will come in to say, why is this happening? So we will look at what kind of infection is it? Was there something with the child's lungs that was not normal to begin with that predisposed them to have this infection or to have the severity of infection? Or is the problem with the child's immune system? So we come in sort of as like detectives to basically help the pediatrician to say, why is the situation the way that it is? And then next step onto the why is what, So, okay, fine. The child has a disease of the immune system, and that is why they aren't getting better, or the child has a lung abnormality that they were born with. So we call those congenital abnormalities. So we come in to say, what can be now done? You've given antibiotics, what next? So we would do further investigations. So that would include special blood tests, further x-rays. Sometimes the child would need a CT scan, and in rare cases, sometimes an MRI. And we would look at those images and then advise the pediatrician to say, you know what, in this case, actually this child is going to need theater. Maybe that there's a mass actually in the lung. All along you thought it was just pneumonia, but actually this child has a lung mass and it's now become infected, and that needs to be taken out. Or this isn't just pneumonia, this is a cyst caused by some parasite that lives in river water. And maybe this little one is from the Eastern Cape, where there are some parasites that we know that can be found in river water that are related, like their life cycle is related to sheep. So we know that if we are told that, no, this child went to the rurals in December and was helping to herd the sheep or was playing by a river, and then they're coming in with this round lesion in their lung that we're seeing on the x-ray, then we'll be like, oh yeah, it's probably a cyst from that parasite. So that's where we come in. We assist to make this diagnosis because it will have not been a straightforward diagnosis. There comes a point in every discipline in medicine where a doctor's knowledge goes up to a certain point. I know we all would love to think that our doctors know everything, but the human body or a human being is so complex and so vast that it's actually not possible to know everything. And even if you have a doctor who is a wonderful generalist, even like your GP, your general practitioner, they can be really, really excellent. But once a problem is located within a particular system of the body, there's more detail, there's more finessing or different disease processes that are specific to different organs that then it's easier and more helpful when you have someone who's then studied further and honed in more on that particular system. So for the lungs, then that's us. So we've addressed the why, right? What is anything underlying in this child? Was this child born premature with underdeveloped lungs, or is this a child with an abnormal immune system? We've gone into the what in terms of helping to diagnose conditions that are not that common. So the kind of conditions that we will we will step in to help diagnose when it's not a very straightforward diagnosis includes conditions such as asthma, cystic fibrosis, congenital abnormalities of the lungs. So these are lungs that didn't develop normally. So maybe there's a part of the lung that's missing, or the shape of the lung has taken a different form from what it's supposed to, or maybe the function of a certain part of the lung isn't working. So like our respiratory system is supposed to make mucus, that's supposed to capture any foreign matter like dust or even bacteria. And sometimes there's an issue with even producing that mucus. And one condition like that is cystic fibrosis. Another condition where the respiratory system is not doing what it's supposed to do is primary ciliary dyskinesia. So inside all our airway, we have these fine, I'll call them hairs, but they're not hairs, they are actually cilia. But just for the sake of my example, just think of them as like fine brush hairs that are meant to like sweep up. They're always like in motion, sweeping up any foreign matter that can come into our airway when we breathe. So if those cilia are abnormal or not formed properly and they don't work properly, your child will have recurrent infections, or the infections will be severe. They just won't really resolve. So we come in to help make such diagnoses. there's certain procedures that a pulmonologist will do that a regular or general pediatrician doesn't do. So one such procedure is called a bronchoscopy. So depending on the condition and what we're suspecting, what's underlying, we may advise that this patient needs a bronchoscopy. And that means we're going to go into the airways with a camera to actually look inside the child's lungs. This procedure is done in theater. The child needs to be completely asleep, almost like they are having an operation done. So it's under general anesthesia. And we will take our scope. So it's a device that has like a long camera. It's quite thin, like the size of a straw. And then at the tip is where the lens and the camera are. And we will put that through the throat, into the airway, through the trachea, and we'll be able to actually look into the lungs to see what there might be. If there's an abnormality, if the branches of the airways are not normal, or if there is chronic inflammation in there, whatever there may be, if it's TB, if it's lymph nodes, if there's cancer, we can also sometimes see that eroding through the airways. And another thing that we are able to do at bronchoscopy is to actually suction the mucus that's in the airways, the mucus that's deep down in the airways that the little one is unable to cough up. And we also know that small children, when they do cough up, they tend to swallow their sputum. It's just a natural response that they have. They don't spit it out. And we often need that sample to assist in making that diagnosis as to what could this be. We send that sputum off for investigations for infections. Sometimes we're wondering, is this TB? So we'll send these samples to the lab. If we're worried about other serious conditions such as surfactant abnormalities in newborns, we would also then need to do bronchoscopy. So we do that. We also do what is called lung function tests. So if your little one or anyone that you know has ever been diagnosed with asthma, it's possible that they've had a lung function test done. And in this test, we basically have a machine that we ask you to blow into, and then it helps us to measure the volume inside the chest and to measure also the ability of the respiratory system to blow. And it will also tell us, after you've blown out everything, how much air, if there is any air left in the lungs. So then with those measurements, we're able to do certain calculations to see, is the lung function good? Is there good amount of lung that is left after a disease? So let's say there was a disease that did cause some lung damage and we've lost some lung tissue. We're going to be able to see how much lung tissue or lung function is remaining. And then when we're trying to diagnose conditions such as asthma, we then do a test of, it's called reversibility. So with asthma, what we know is that the airways actually contract, or they will go into spasm when someone is having an attack or when they are frequently symptomatic. And they should be on inhalers. And what the job of the inhalers, besides calming down the entire system, is to actually relieve that spasm and get the airways to actually open up. So when we do a lung function, we will measure all these pressures and the volume of the lungs, and we will then give this child the same medication that is meant to open up the airways, and we'll repeat the test. And based on the measurements before and after those bronchodilator medication was inhaled, we'll be able to deduce that this is most likely asthma or not, based on the amount of, we call it reversibility, but the amount of opening up that the airway actually does. So those lung functions are something done by pulmonologists. There are technicians that can do them for us, but we interpret them. And when we are managing a patient or following a child up, we will do them at intervals to actually see if there is a decline or an improvement in the child's lung condition. Other special tests that pulmonologists do can also include sleep studies. So I get a lot of questions on social media about sleep apnea and little ones who snore and sometimes even stop breathing while they're asleep. So we do sleep studies to actually measure what is happening while this little one is sleeping. It helps us to assess whether or not they are snoring, and if they are, how much time in the night, how much time, how many intervals in the sleep duration are they actually either not breathing or breathing so low that they're not getting enough oxygen. And we know that if the sleep apnea is so severe that it's causing low oxygen levels for a significant duration of the night, it actually will cause increased pressure on the respiratory system and then also the heart. So that is why it is so important to not ignore snoring in children. It can be quite a serious thing. I know some children snore when they have a cold or a flu, and then that can resolve afterwards. But there are children who snore every day, every night, no matter whether they are ill or not. That needs to be assessed. Okay, so we do those. There are other investigations that we can do that help us to diagnose conditions, but those are like the important ones. And we will inform and come up with the diagnosis. We will come up with the treatment plan for those conditions that are treatable. Some conditions are not treatable or are not curable. And in those instances, we will then be talking about how can we support this child to have a good quality life. Our aim, really, at the end of the day, the function of a pulmonologist is to, first and foremost, by all means, to try and resolve the issue. So if the issue is a chronic cough, if the issue is wheezing or recurrent wheezing, if the issue is shortness of breath or anything related to a breathing issue, our first priority is to resolve the issue. If the issue cannot be resolved, we then will do our best to optimize. So to try and get this child with that condition that is not curable or solvable to have the best quality of life that they can have. And then also, with most conditions, whatever has hurt or damaged the lungs, there is some part of the lung, usually, that is still okay. So we try by all means to preserve what is still good. And that also requires a very specific plan. It's quite a multidisciplinary process that we undertake. We work with other people, and then we will then monitor the child. Okay. So when I say multidisciplinary, who do we work with? Okay. So we work very closely with pediatricians. We are first and foremost pediatricians. So I am a pediatrician. So I will know the common things that we pediatricians see and treat. So I will get my referrals from a pediatrician. So we work together. There are some patients who we would monitor and follow up their entire lives, or at least until they are adults. And then there are some children who I will intervene and assist and treat. And once we're on top of everything, I will refer back to the pediatrician. Everything is fine. I don't need to see that child going further. So pediatricians and pediatric pulmonologists do work closely together. We also work quite closely with ear, nose, and throat specialists. And this is because the systems are very related. In fact, we do spend quite a bit of time debating as to where does their system end and where does our system start. Because ENT doctors have to deal with everything that's got to do with the throat, and that then leads into the breathing system of the trachea. So somewhere on the way down, pulmonologists then take over. So many of our patients, we will refer to an ENT doctor, because if a child is having issues of the upper airway, be it the nose, be it the ears, recurrent or severe otitis media, or anything to do with the larynx, if you don't resolve that, it will aggravate whatever underlying lung issue that there is. So we do refer patients to ENT doctors. Some children do need to have either their tonsils removed or their sinuses cleared, and vice versa. ENT doctors also refer a lot of patients to pulmonologists. We also work closely with dietitians. It's very important when you're trying to optimize any lung condition that the child's nutrition is also optimized. And we deal a lot also with allergies. So some children now will have certain dietary restrictions, and parents will be wondering, okay, if you're saying my child has a cow's milk allergy, what can I give my baby? So that's where we work very closely with dietitians. We work closely also with speech therapists, because another reason why a child can have recurrent pneumonia or severe pneumonia or chest issues that just don't seem to resolve could have to do with things related to their swallowing mechanism. So the speech therapist can help us to assess and decide if there's actually an issue with the swallowing. Is this little one, we call it aspirating, but choking on their feeds. And sometimes when children choke, it's not so obvious. So what we all expect is that when I've had something to eat and I'm choking, I will be coughing a lot or spitting. But there are children who we call silent aspirators. And so they're actually choking quietly without actually showing any outward signs. But we will later find out by the fact that their lungs are getting affected and damaged. Okay, so those are the speech therapists. We also do a lot of referrals to them, and we also get many referrals from speech therapists. We also work with physiotherapists for children with chronic lung diseases, especially those that involve increased mucus production or an inability to clear their mucus. So in some conditions, some children actually are unable to cough, or they have muscle issues and their cough is not strong. So to be able to actually cough and clear out any foreign matter that's in the airway, you need to have good chest muscles. They need to have a decent level of strength. So if that is not possible, then the physiotherapist will come in and give the patient, the child, exercises that they can do, which can help them to actually clear their mucus. If it's a small baby, they might even help with like suctioning out mucus. And then just whilst we're talking about suctioning, I just need to address this little matter of babies being suctioned. So I'm often asked when moms have little babies who are a bit chesty or are having some coughing issues that, this child has lots of mucus, doctor. It's because they didn't suck it out when the baby was born. Okay, so it's not routine. I know we see it like on TV and in movies and things, but it's not routine for suctioning of newborns, that they will have their things sucked out of their nose and mucus sucked out of their mouth. The body and the respiratory system is it's actually, under normal circumstances, an amazingly perfectly created system. So God designed it that babies are actually able to clear their own secretions, and that bit of mucus that they're born with, they will ultimately clear it. It does not need to be sucked out. And if you're having a small baby or a child that has excess mucus, then that's something else. It's not related to the fact that when they were born, the mucus wasn't sucked out. All right, so that's who we work with. Those are the kind of children that will be referred to us. We will often follow these patients up. So there are conditions where maybe I'll see your child like once or twice. Maybe there was a hospital admission for a pneumonia that was so severe and it did cause some lung damage. Maybe your little one needed a drain in the chest to drain out some pus, let's say. The body is such a perfect system, like I say, that oftentimes there will be complete resolution of any side effects. So I will follow that child up maybe for 6 weeks to 3 months and find that everything is okay. And I'm happy to discharge that patient from pulmonology follow-up. But there are children with chronic lung diseases that need lifelong follow-up. And that includes conditions such as cystic fibrosis, that includes conditions such as asthma, conditions such as primary ciliary dyskinesia. There are many. So in that instance, we will be working hand in hand with the pediatrician, and probably 2 or 3 times a year, a child like that would need to be seen by their pulmonologist to assess, to make sure that things are still okay, to measure the lung function, in some instances to repeat the CT scan to make sure that the disease is not progressing or progressing too rapidly for those conditions that generally are progressive. So there are patients who will, for their entire lives, follow up with a pulmonologist. Once the child turns 18 or 16 for some pulmonologists, we will then transfer that child to an adult pulmonologist with a nice referral letter and everything that they need to know about this child's history, and then they will carry on with that follow-up. Other babies who may or may not be followed up for life includes those babies that were born very premature. So I'm sure you've seen on the socials, preemie mommies often share their stories about their NICU stay. It's quite a tough journey that they go through, and every day in the ICU matters, and that's why they often count the days, and you'll meet babies who were in the ICU for 30 days or 100 days or however many days. Not all, but many of those children do actually go home on oxygen, and that is because their lungs have still not fully developed by the time they're discharged, or because while they were admitted, busy gaining weight and basically fighting for life, they may have gotten a chest infection or other things related to having them on life support, on ventilation, could have caused some damage to their lungs. So those children will be discharged on home oxygen. So those little ones can also be followed up by a pulmonologist. It's not always the case. Some pediatricians are happy and comfortable to follow up those preemies themselves. But I do believe that if a child is discharged from hospital on oxygen, they definitely do need to be seen by a pulmonologist, so that as they grow, we do ultimately get an opportunity to measure their lung functions and see how we can support them, what vaccines they need, and if there is any permanent damage that has been done. So I hope this is sort of helpful and has removed some of the blurriness around pediatricians versus pediatric pulmonologists. In most instances, it's preferable for a child to be seen by a pediatrician first and then referred to a pediatric pulmonologist. But it's also okay if some parents want to self-refer themselves to a pediatric pulmonologist because maybe they are frustrated. I've been going to the pediatrician doc for 2 years and this cough is still unresolved. We don't sleep. My child is always on antibiotics. My child is always on Aspirone. Please, can you help? I will see those children. And if I find that there was just some minor tweaking that needed to happen and the pediatrician can carry on, that'll be the case. But in some cases, you do find that, oh gosh, there's a condition here that has not been diagnosed yet that definitely needs a pulmonologist. So I hope this has been helpful. And if you have any questions, you can post them. I will respond. If you have found this helpful, please share with friends and family. And please don't forget to like the video. And if you are interested in the others, you can subscribe so you can keep up with all the rest of the things that we'll be sharing. Thanks.